Welcome back, everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim, and co-host across from me there, we got Ray Pace, Dr. John Hill, and returning yet again for now his third episode, Dr. Jordan Singer. Hey, thanks for coming back, and we got a dual doc special. We got a doc dual special is what I really want to see here, right? All right, let's ask challenging questions, and then when we have them on air, right?
All the
see if we can get three different answers from two different docs, right? But psychiatric emergencies, right? We've spent a fair amount of time on the pharmacology in previous episodes, but let's talk this time around specifically about the capacity components of this. Let's talk about the mechanical restraint components of this and some best practices there, and then some other things that surround that with documentation and whatnot. So I guess, first and foremost, let's hop on the capacity thing, right? What gives us, when do we restrain either chemically or physically these psychiatric patients? Where do we start with that?
Yeah, so there's two situations where we are going to be asked to transport patients to the hospital against their will.
Yeah.
And in those situations, we may have to use chemical and physical restraint. And if we ever do use physical restraint, it should always be in association with chemical restraint, because fighting the physical restraint can be quite dangerous for the patient, and we don't want that to happen. But these two situations are when they lack capacity and then when they have a pink slip in place. And so if a psych patient or someone with a psych emergency lacks capacity, you do not need a pink slip. But if they have capacity and they also have a psychiatric emergency that puts them at imminent risk to self or others, that is when a pink slip is needed, because you can't force them medically because they have capacity, but we know they need to go. And so you bring up the first thing, which is what is medical decision-making capacity, because this is something we have to do for every refusal and transport, which is there's 4 components, and if a patient meets all 4 of those components, they have capacity, and we need to respect whatever decision they make, whether we agree with it or not.
Right, yeah.
And these are, they need to consistently communicate a choice, so they're verbalizing, I want to do this, and they're pretty consistent with that, not bouncing all over the place. They need to understand the medical issues at hand, so understand what could be going on and what that actually means. They need to understand the consequences and risks and benefits of going to the hospital, not going to the hospital, doing X, Y, and Z, and then they need to be able to reason through it in a linear way. We may not agree with their reasoning, but it at least needs to semi-make sense how they got from point A to point B. Right. And if any of those components cannot be met, they lack capacity, and then we are legally obligated to do what we believe is in their best interest. But if they have capacity, we are not allowed to transport them against their will, because that would be kidnapping in that situation.
And I guess, we've joked about this on some other episodes, but it seems like the subplot of this is, call med control is your friend, and this would be a situation where, I don't know, maybe 10 minutes ago, right? Exactly that happened, and we were recording another episode with you, and exactly that case. You want to talk? Can you just talk about that case in broad terms? That just he took that call, just a few minutes ago. So
I had a crew that was at the scene of a patient who they were worried lacked capacity and was refusing to go to the hospital. And so in that situation, if we don't transport them when they lack capacity, that's patient abandonment. So the crew correctly identified that this is very nuanced. This person was kind of on the board of, he wasn't sure if she did or did not have capacity, so he wanted me to talk to her so that I can give my impression. And I completely agreed with him. I thought that this woman lacked capacity, and even though she was refusing to go, we had to do what we were obligated to, which was transport her. And then I gave him recommendations for sedation if need be, but said, hey, if you can kind of convince her to go, it's best to do it without sedation, but we're going to get her to go regardless. And if it escalates to the point of sedation, here is what I recommend to, this is the safest option in that situation. And then the reason that it was beneficial that he called me is, one, we now have him thinking she lacks capacity, I think she lacks capacity, and it's on a recorded line so that we can review it later. Or if there's ever question after the fact, we can say, well, this is you talking on the phone, and it's pretty obvious
you put her
after
on
the fact that you couldn't demonstrate capacity. So it's medical legally protective to call your medical director or med control to kind of discuss it to make sure we do the best for that patient.
Yeah, and I don't know if that was outright stated agitated, but you had the patient put on the phone.
Yes.
And you spoke directly
I
with
spoke directly to her,
Right.
which is important, and you should request that med control do that. Not just, I think they lack capacity, but ask that physician speak with the patient and really make sure that they agree with you.
And the other thing too that I like that you did there, you pre-planned any type of hurdles.
Mm-hmm.
Like, if you already planned out if this, if the patient becomes combative and stuff like that. So it's just, I like that, and I like that you did it that way. It just makes it easier. That actually avoids another call.
Correct.
So, and that's maybe a good tip for some of the providers if the physician doesn't do what you just did. Okay, if the patient does lack capacity, and I want to get them to go and they become violent, this is what I'm thinking. I'm thinking of giving some Versed. Mm-hmm. Are you okay with that? And sure, up to a max of this. Okay, great. And then now we have that one step forward thinking, which I think is very beneficial in the patient's care. Mm-hmm. And then that's also going to avoid a repeat call or any type of delayed care.
Yeah, we have the luxury of having so many EMS board certified doctors, let alone EMS minded doctors in the UH system. But there are those. You're absolutely right. There's those ER docs that don't have a full sense of what goes on in the EMS world, or what they should plan for, or what's going to unravel. It becomes incumbent upon us to prompt them, right? Because again,
we're lucky.
Asking that is not an unreasonable question, right? We're lucky in the fact that most guys like this are going to say, hey, and then I can see how this is going to fall apart, right? All right, let's do this. Here's your order set. But it's also not inappropriate to say, all right, doc, cool, we're going to do that, but how about we pre-plan for the next thing, right?
Yeah, I think it's a good thing. And then sometimes, to your point, I believe that we are sometimes spoiled in that nature. Not all of the physicians are board certified in emergency or in EMS or is engaged with EMS as well. It just might be like, okay, I answered your question, and it's no fault of theirs. Right. It's just like, I answered that question, and if you have another question, you'll call me with it. Whereas I think our approach, and we're very lucky here at university hospitals with our physicians and how engaged they are in EMS and with making our education and being so involved in the ambulances, I just think you get a great level of care, a great level of comfortability having that conversation with a physician as well too, because so many times on here we've had that conversation about the old mantra of I'm scared to call medical command, and it's like, no, I called John the one day and it was totally deemed toward like this awkward pink slip situation. I'm like, let me run this by you. This is where my head's at, but here's all the facts. What do you think? And it's just a comfortability level too.
This is very nuanced. There's times where I get these calls in the ER and I may consult the other physician who's there because there's lots of shades of gray. When it's easy, it's very easy. If they lack capacity, sure. If they have capacity, but this gray area in the middle, in the end, we just want to do what's best for the patient. We want to get it right. We don't want to steal their rights and force them to go against their will unless we actually need to do that.
Yeah, I agree.
So that escalation, and you already kind of mentioned. You kind of jetted ahead, which was good because it needed to be said. Was the use of chemical restraint with physical restraint? Is there that makes a logical progression? I had to physically restrain somebody. Now we'll add the chemical restraint. Is it ever appropriate to chemically restrain them alone, right, before physical restraint? Or if I chemically restrain somebody, do I have to physically restrain them?
So if you have someone that's so agitated that you think they need chemical restraint, they're probably going to need to be held down physically to get that. So you really aren't going to need to necessarily sedate someone without physically restraining them. And then also if their chemical restraint wanes and you're not watching them closely, they could get very agitated and potentially hurt you in the back of the rig or jump out into traffic and hurt themselves. The reason we're sedating them is for everyone's safety. Yeah. Most importantly, that patient who's being sedated, they are potentially going to get hurt from their agitation, and we want to prevent that. And then if you have someone who's physically restrained and they're not fighting the restraints, like they're sitting there calm, it's not mandated to chemically restrain that person. They're not fighting the restraints. They're not hurting their extremities. They're not kind of developing muscle breakdown and rhabdomyolysis and hyperkalemia and lactic acidosis from the fighting, but if they are fighting, they need to be chemically restrained. Absolutely. Because if we don't, they can actually suddenly die from this. It's been seen before.
Yeah, absolutely. The one thing that's kind of always I don't want to say it's a stumbling block, but we tried to write it as crisply as possible when we broke the protocol down. And for those who don't know or seeing this outside of our UH sphere, if you will, is we've broken it down to agitated patients. We've broken it then to one column for agitation. We've got one column for combative patients, and then we've got one column for violent. It's basically a force escalation left to right across the page, right, from agitation to full bore. Somebody's trying to kill you. Essentially, is the way I so ineloquently put it. Up to the use of ketamine and subsequent restraints. Really a question for both of you, because I think this comes down to you need to interface with your doc to understand where they believe these lines are. That combative versus violent patient, right? Where do each one of you individually draw those lines where you would switch from using the way our protocol is currently written, midazolam and haloperidol in the combative patient, to something more aggressive like major tranquilization with ketamine, right? So where's that trigger for each of you individually? And I say that really to hammer home the point that, I think every doc has a little bit slightly altered trigger for where that exists, and you need to know it. You need to know what your medical control wants, right? But personal opinion, right? Personal opinion is what I'm looking for here.
So for me, if somebody's mildly agitated but you can talk to them, they may not need anything, but if you think they're starting to ramp up, then it's worthwhile to get something on board, because obviously the EMS pre-hospital world is stimulating, but we know that the ER can be very stimulating, and someone might be kind of calm and then get to the ER and lose it and need to actually be heavily restrained. So that's the person who I just get maybe a little bit of IV, if you got an IV Versed or IM Versed or intranasal Versed if you don't even want to stick them. Or we have Zyprexa dissolvable tablet that if they're more psych related, you can kind of get something on board so by the time they get to the ER, they don't escalate and have an issue. If they're already kind of combative and you're like, okay, we need something now, they're already at the point where we have to do something. If it's more medical, I give them Versed. If it's kind of more psych, I give them Versed and Haldol IM. The reason is Haldol seems to take too long to actually calm them, and so getting both on board kind of allows the situation to be stabilized to some extent, but also getting an antipsychotic.
And it stabilizes it for longer. Right?
For longer,
yeah,
right?
Absolutely.
And they probably need the antipsychotic, so Versed monotherapy probably is not sufficient there. And that's the person they're kind of fighting, but you can kind of talk to them and communicate them with a little bit. And if they don't get sedated right now, you're not worried that they're going to suddenly die. The person who needs ketamine is the person who is so profoundly agitated. They're full on kind of Hulk mode. They're throwing people left and right with just one arm. They're running into traffic. You're like, if we don't control this person right now, they're probably going to die or very much critically injure one of us. That person needs ketamine as soon as possible, mostly for their safety, because they're at risk of running into traffic, getting hurt. They're at risk of sudden cardiovascular collapse from fighting and developing all that metabolic derangement. And we have no idea what even put them in this situation. What if they're a head trauma patient with a head bleed? What if they overdosed on cocaine and they're in like a wide complex rhythm and they need to be resuscitated with bicarb or any number of other things? We can't even start that resuscitation until they're sedated. So because of that, if I need to control them right now, it's ketamine or nothing, basically.
I'm very similar. If you have a reasonable patient, not necessarily 100% reasonable, but you can have a conversation with them, they're willing to, I'm really agitated, but you can offer, like, if I give you a pill, it's going to help calm you down. Are you okay with it? Yeah, then I would go olanzapine. I'm probably more towards give them both the benzo plus the antipsychotic on board, because 9 times out of 10 there's some psychotic
component to it. Sure.
So I like both. But yeah, if they're willing to take something and they don't want to get an IM injection, although some people do because it's not their first rodeo. They know what's going on. They said, yeah, last time this happened, I got the IM injections, I felt better. They might want that. So if you talk with that patient, that's a reasonable patient you can work with, and you'll get away with some IM Versed, intranasal Versed, oral olanzapine, or IM haloperidol. For me, I guess it's kind of the both, the reasonable patient versus kind of agitated, but you can still talk to them, or it just takes a little bit of effort to like calm them down, put some hands on the patient, IM injection, hands come off, then they're a little bit more calm. You can do that. I just had to do that to a geriatric gentleman who had a cane on him in the emergency department. Someone allowed him to keep his cane in the emergency department.
Which turned into a club.
So
promptly turned into a club. Yep.
he was getting very excited in the afternoon, sign up to me as it always is because he's a he's starting to ramp up, yell and scream. They verbally de-escalate him in the emergency department. I don't even have to go over there because my staff's great. And then he starts verbally getting louder again. I go in there, I talk to him. He is obviously motherfucking me because he doesn't like me. And then I come back, I order meds, I go in very slowly, I approach him, I grab him so I don't get hit with the cane.
Sure.
We move him to the bed, we give him medications, hands off, don't even have to restrain him other than just to make sure he's not going to hurt himself or us with his weapon. Get him into bed, give him his medications, hands off. He's yelling at us, but he's quickly becomes sedated. If for ketamine, I do like ketamine for the combative patients. So if you, EMS, or police is wrestling with a patient, that's an appropriate patient for ketamine. There's often times where they are calm in the squad. Squad calls report, says, hey, I got an agitated patient. For whatever reason, our police that day have 7 people on board, and they're bored, so they walk out, and you open the ambulance bay doors, and now you've got 7 cops, and then that guy's going to get agitated right then. It might be good to pre-medicate him before he's in the hospital. And then he sees these 7 cops, they get agitated, now we're having another fight. Right. That's when I do ketamine. So anytime you have to really kind of go hands-on to protect you, protect the patient, and it's taking some effort for you to do that, that's when you do ketamine. Obviously,
that's your trigger. Yeah.
That's my trigger. I mean, I know Dr. Spanner says if you wish you had a stun gun or a taser, that's when you use ketamine. That's the type of thing. You want a combative patient, a good medical reason why you need to take them down now, and ketamine's going to do that, right? 45 seconds, 60 seconds, IM injection, they're going to be completely out and with it. And then you can start your assessment and start put the first thing I'm going to do is blood sugar and EKG on them, right? Because those are the things that I can make sure that there's nothing bad going on there. They're going to go on their monitor because they did just get sedated. We're going to monitor their SpO2 and they're going to start working.
Capnography.
Yep, and start working all that.
Because if you give Haldol and Versed to this patient, it's going to take 5, 10, 15 minutes before you can start that assessment. They're still fighting. And if something life-threatening is going on, you're 5, 10, 15 minutes behind the 8 ball, and you're behind. And so in those situations, ketamine is really the best option for rapid control of the situation.
You did kind of hit a very important point there, is post-administration monitoring for all of these of these patients, right? No matter what agent you choose, right?
Capnography is required.
Required. Yeah. Yep. Capnography, pulse ox, absolutely required.
If you sedate a patient, they are by definition a critically ill patient because you thought it was necessary to sedate them. So Q5 minute full set of vitals. You already mentioned EKG, blood sugar, capno. If you think, should I do this for this patient? The answer is yes. Just do all the things.
No, that's a very reasonable way to approach it, right? It's just that bundle of things for every time we pull the trigger on any type of out-of-hospital sedation, right? It keeps people safe. Were you going to say something?
Yeah, I was going back to restraints. Yeah. Understanding that for us in the medical community, handcuffs are not a restraint. If they're in handcuffs, a police officer needs to be with them because you would assume that they're in custody at some point. They are no longer free to go. They are in the care of a police officer. You're not a law enforcement officer. You can't take custody of patients.
Correct.
Officer needs to be with them if they're going to be in handcuffs. Officer needs to be in the back of the squad.
Not just following.
Not just following with a key to it, because if something terrible were to happen in the back, insert whatever disaster you want to have, Or if that ambulance goes off a cliff and you need to get to that patient, unlock that patient's handcuffs, the person needs to be in the back of the ambulance.
Correct.
Yeah, absolutely. Yeah.
And that brings up another good point. So even if they're in handcuffs and arrested, if we administer any form of sedative, they're our patient. End of story. Like, you cannot let police transport a patient that we have administered any form of sedative.
Yep.
There's no question. No, like, we can never do that, and that's how some EMS agencies have gotten in trouble with the law, and we don't want to ever allow that to happen.
Yeah, I think we talked a little bit about that. Like, at any point in time that we have given any type of sedative to a patient, we obviously have capnography required, and transport to an emergency room via an ambulance is required. There is no, like, passing them off. I agree 100%. And that's where people just get in trouble. That's just not a good standard of care to try to do that. It's just wrong.